So without further ado, it is my pleasure now to introduce our first speaker, who is Dr. Jeremy Nell from South Africa. Dr. Nell's presentation will focus on clinical pathways and the way guidelines have evolved since the emergence of ART to present. Dr. Nell is a physician who's trained in internal medicine and who has had subspecialty training in the field of infectious diseases. He has had further training in the United States in the field of transplant infectious diseases. Jeremy is a member of several guideline committee looking at HIV guidelines and a member of the South African HIV Clinician Society. He's also well published in HIV and opportunistic infections. Please welcome with me Dr. Nell as he gives his presentation. Thank you.
Great. Thank you for having me. And it's a great privilege to be able to talk on this topic. I'm going to be talking on rapidly changing guidelines, particularly how they relate to the resource-limited settings, which many of us work in. And I'm going to cover really three key aspects here, and they all interrelate. So the first is the problem of this deluge of information. So we're getting so much new information about HIV and about other things that are relating to guidelines, and how we cope with that and how we synthesize that. And then I'm going to talk about how to design guidelines so that they can be adapted quickly and be nimble and be able to adapt when new evidence comes in. And then I'm going to be talking about how to get this new information when it does change the guidelines through to practitioners on the ground and healthcare workers and other interested parties. So I'm going to use some examples. We've heard a lot about HIV. I'm going to use some examples from COVID as well. This is perhaps the best example of what it felt like in the early days of COVID, to see all these new papers coming through every day. There's huge numbers, often thousands of papers at some points, which were coming through every week, and which really were of very limited evidence in the beginning and very limited quality often. But we were required to read a huge amount to try and get some idea to guide what we were estimating people should be doing. And you can see this in the COVID world, how these numbers took off. In the beginning there of the epidemic, just by April of this year, the numbers were rising exponentially in terms of number of papers. And if you look at the peer review system on the top there were over 3,000 papers in COVID just by April. The doubling time was estimated as anywhere between 14 and 30 days for new papers. And by now, as of last week, there are over 72,000 articles mentioning COVID in PubMed. And this number continues to rise at an exponentially high rate. Very difficult to stay on top of a lot of new information, and very hard to make sure that you're up to date with the key papers that inform information and inform decisions. An analysis was done in July of this year, so that's a few months back now, really showing where the papers were coming from. And you can see there that the areas which were hit by COVID most by July, United States, China, Italy, and United Kingdom, were also, not coincidentally, the countries which produced some of the most number of papers relating to COVID. And you can see that the HIV world is almost as bad in this sense. It's on a slower scale. Fortunately, we haven't had the epidemic moving anywhere near as quickly as COVID. But you can see here that in 2020, there were over 16,000 papers on HIV in this paper alone. And these numbers rose obviously exponentially early in the 80s after HIV was discovered, plateaued a little bit in the 90s, but have been rising steadily since. So whether you're looking at HIV or whether you're looking at COVID, you're dealing with a huge number of papers that come through every day, every week, every month, and every year. So how did we combat this? Well, in the COVID world, initially, the best way was really to find key important people who were looking at these papers with often more time than you or I had, hopefully, and were able to sort of synthesize these papers together and give you links to the key papers that they thought. So we were really using key people as almost reviewers of the evidence in an informal way to list the papers that were important. This is an example from Paul Sachs, who's, of course, one of the doyens of the HIV world, who was doing incredible work and continues to do so by collecting some of the interesting papers and putting them together in an article where he would, or a blog post often, where he would have some extra comment as well, loosely analyzing these papers too. Very, very helpful early, but it's a fairly unsystematic way, as you can imagine, of getting this data. And there's no great guarantees that he hasn't missed some, as he himself alluded to in this tweet. So what are some other ways? Well, as time went on, some of the researchers started looking at seeing if AI, artificial intelligence, would help with the huge number of papers that were coming through. And they were looking at, like, for example, this artificial intelligence website called SciSite, which would link a search term that you had and with other papers which were similar. So it would find topics that it thought were similar and make sure that you didn't miss any of the big ones. And they could be linked by the authors or which groups they were in at which universities. I think it's fair to say that the AI impact on the COVID epidemic, in terms of papers at least, has been fairly limited. I think that people struggled, even with the best AI, to get the best, the most relevant papers with any particular topic. And then as time went on a little bit, what happened is some key groups with more resources and more experience with systematic reviews and looking at evidence in particular started collecting these key papers in a more systematic way. So this is an example that I really like from the American Society of Healthcare Pharmacists. And what they've done is they've collected the evidence for a huge number of agents relating to COVID, that they systematically go through and make sure that the good evidence is really collected. And you can see there from this list the diversity of agents that they're looking at. This is one page of them, and I don't mean for you to possibly read this in such small font, but just to give you an idea of the depth to which this group went to. This is relating to interferons here. And they've gone through and done a systematic review of some of the evidence here, and with comments as well, and insights and ways of evaluating this evidence, also linking to other guidelines such as the NIH guidelines, and telling us what the NIH guidelines assessed the evidence for. So this is a way, if you were plugged into this sort of system, where you would be able to get a lot of information and in a much more comprehensive fashion, and a sort of high-level way where other people have done some of the synthesizing of the evidence for you, and to make sure that some of the key evidence wasn't neglected. Cochrane was another group. This is just two examples I'm going to give, but there were many groups which did this sort of thing. Cochrane, of course, famous for its reviews, and they also looked specifically at some COVID-related questions. I'm going to show you one as an example. This is about the antibody tests relating to SARS-CoV-2. And here again, you can see the number of authors there and the expertise available. And this Cochrane group, in this particular group, this is one table from this paper. I'm not trying to show you the entire paper, of course, just to give you a representation of what was done. This was looking at the immunoglobulin sensitivities in COVID in terms of testing. And you can see there at the bottom there, between days 8 and 14, they assessed as a meta-analysis that the IgG was about 66% positive, sensitive. Between weeks 2 and 3 was about 88% sensitive, and after that it went up. And you can see that over all time points concerned, there was 99%, which really implies that these tests are very good, but you can see that they may not be good early on when the tests are often most needed. So this is an example of what Cochrane were able to do. And there were, of course, many other groups. I'll give you one other example of what we did in South Africa in terms of the COVID-19 epidemic, the evidence problem. We had a subcommittee of a national group look at this, and really these people donated time and huge amounts of time often to look at these agents that we were interested in writing about. And these were important because whatever that was decided here fed directly into our own national guidelines about COVID. And we have a very similar process when it comes to HIV, but this was arguably even more rigorous in terms of COVID. So this group assessed each of these agents that were thought to be plausible for COVID-19 treatment in terms of benefits, in terms of harms, by what's called a PICO analysis. So that's a population, intervention, control, and outcomes analysis, which I'll talk more of in a second. Then did a systematic evidence review based on that. So in other words, you would define your question, you would define what interested you and which outcomes were important. Then you did an evidence review looking at those outcomes. And if it seemed favorable, we would also consider things like cost effectiveness, because we're a middle income country, and many of the agents, which may have very small benefits at very high cost, would be applicable maybe more to the high income countries, but less so for us in the middle income countries. And we fed them into the national guidelines. They are publicly published as well, which was important in terms of transparency, so that other stakeholders could have a look at what we were looking at and seeing how the evidence was translated into decision. And then it was very time consuming. but extremely helpful, and of course provided local guidance to us in South Africa and potentially as well to other similar countries in the region, and in the same middle income country bracket in terms of income. And then this is another example I'm going to show you. For example, this is again looking at interferons. We had a key findings section. We had a recommendation section at the bottom, which really had options which were much more stringent in terms of either recommending for them or against them, and the reason why we did that. It is summarized there in the key findings, but then later on in each report, there was a much more detailed analysis that went into the evidence. And then, of course, often at the end, into individual trials, really analyzing them in depth. So you can see how the amount of time that it takes to go into all of this. But this is useful in the sense that it made sure that for all of these key drugs, the key papers weren't being missed, that it was systematic, that the evidence and the decisions we were making based on the evidence was taking into account the best trials possible and making sure that we weren't missing any. And of course, this is really just a reflection of something called the GRADE group, which really provides the best way to draw up guidelines. And we don't have anywhere near enough time to deal with this in this sort of talk, but it's well worth looking up if you're not familiar with it. And this is really a sort of an objective, or at least as objective as possible way of drawing up guidelines that are transparent and that are systematic and that make sure that we're moving from evidence to decisions. In other words, guidelines recommending or not recommending something in as objective a way as possible. So for example, you'd formulate the question, you would do that PICO analysis that I mentioned, you would grade the outcomes. Some may be very important, such as death. If you're saving lives, that's very important. Whereas others you may decide are less important, such as maybe cost effectiveness or something like that. And then you would effectively grade the evidence as it came through, and then move from that evidence to a firm recommendation in either way on a guideline, but with a clear idea of being transparent. So you'd be able to make sure that you're explaining why this evidence is translated in the following ways to a recommendation for or against it. And then, of course, you'd factor into other factors, not just the quality of evidence, but also the risks and benefits and things like values and preferences and cost effectiveness and equity and feasibility. So all these other things that you may not routinely think about when you're drawing up a guideline. It's really helpful to have this framework in place so that you can make sure that the guidelines are as comprehensive as possible. And this is really important when it comes to these rapid decisions which have to be made in terms of new evidence, either in HIV or in things like COVID, where as much as this seems time consuming, it's a really good safety net to make sure that we're not missing any of the big key important factors that we'd want in terms of a guideline. In terms of other questions that popped up, so how to update a review, we had these questions about, do you update for every new paper that comes out? Do you update for key papers only? What about papers that are likely to change recommendations versus others are not? These are very difficult questions for which there are no clear answers, but you need to think of it because you can't keep updating recommendations based on every paper when you remember how many papers are published in each day. How to design guidelines that are nimble, rather. So I'll give you one example that we did again in South Africa about the HIV Clinician Society guidelines. We made sure that the newest ones in 2020 were modular. So we made sure that they were designed in a way that you could get a specific information quickly. And then you could update them individually. And we're still debating actually whether to turn them into a website versus an app. Websites being cheaper and usually requiring less maintenance because every time the operating system of a phone changes, you don't have to move on and update the entire software again, versus apps, which are often more user-friendly, but and they don't necessarily require active internet, but do require a lot more upkeep to make sure that they continue to work as the software of a phone updates. And then the other thing is how to signal that you have new changes. And we have sections in our guidelines which specifically say what has changed. And that's really important in a guideline that has to adapt quickly. It's important that reviewers or people who look at it are able to know whether or not what has changed and be guided to just those bits so they don't have to read the entire guideline again. And then lastly, we have the issue of how to push this information to healthcare workers. And we've got a variety of ways we try, but there's many other ways, and each have their own pros and cons. So, for example, SMSs, which come directly to the practitioners, emails, which people sometimes just delete, but which allow for more information. And then webinars, when we have a lot of changes, we often try and get key speakers to speak about that. And that really, we seem to think helps, but there's lots of other considerations. So in conclusion, we've really got those three factors to look at. One is if you get a lot of information which is new, and we know that that's true of the HIV world and other worlds like COVID, how do you make sure that you're doing it systematically as possible to make sure that this information is not being missed when it's a key piece of information? Secondly is how to make the guidelines reflective of that so the guidelines themselves can change quickly. And then lastly, how to communicate any of those changes directly to people in a way that's efficient and effective and that gets people to act on the new information as it comes through. I don't have all the answers, but this is some idea of what we've done and what we think may work and some ideas for others to use as they see fit. Thank you very much.